All of them were free from severe hypoglycemia, and they all achieved an A1C less than 7%, which is just like really incredible. This is the Rounds Table. All right, welcome back, listeners. I'm very excited to have a brand new guest on the show today. It is Danielle Cutler, and at the time that this goes out, she will be a third-year medical student at McGill, ready for the wards. Danielle, welcome to the show.
Thanks so much for having me.
All right, Danielle. So this past weekend, aka the weekend of June 22nd, was the American Diabetes Association conference. I think it was in Chicago, but to be honest, I didn't go, so I don't know that for sure. But I thought it would be fun for you and I to chat about 3 potentially practice-changing studies that were released at ADA. I have 2, you have 1. Maybe I'll go first if that sounds good to you.
Sounds great.
All right, so first up, we have once monthly Maridebart Cafraglutide, oh gosh, that's hard to pronounce, for the treatment of obesity. This was a phase 2 trial published in the New England Journal of Medicine, and I'll just hit the listener with a research question. So is Maridebart, apparently that is the shorter name of the mouthful that I'm sure I butchered, is Maridebart, which is a long-acting peptide antibody conjugate combining GLP-1 and glucose-dependent insulinotropic polypeptide receptor antagonism, superior to placebo for weight loss among adults with obesity.
Sounds cool. So how did they design this study?
Yeah, good question, Danielle. So, the listener will be familiar with drugs similar to this, such as tirzepatide, but Maridebart is a once monthly injection. That's wild to think, okay? Tirzepatide once weekly, this is once monthly. So they conducted a phase 2 double-blind, placebo-controlled dose-ranging randomized trial of various doses of Maridebart from January 2023 to September 2024. The population primarily included adults with obesity, but they also had a sub-cohort for patients who also had type 2 diabetes. Some of the key inclusion criteria: BMI of 30 and up, or 27 and up if they had an obesity-related comorbidity, such as high blood pressure. For the diabetes cohort, it was okay if they were on other diabetes drugs like metformin or an SGLT2. A few key exclusion: history of pancreatitis, recent change in body weight, planned surgery for weight loss, use of weight loss meds. The intervention, this once monthly injection at multiple different doses. So there was a 140 milligrams once a month dose, 280 milligrams once a month dose, 420 milligrams once a month dose. There was also arms that allowed for escalation of the medication, as well as another arm that looked at 420 milligrams every 8 weeks without any dose escalation. The comparator was placebo. The outcome, percentage change in body weight, and the timeline was 12 months.
Cool. So how many people did they have in the trial?
So just under 600 patients in total. The average age was 48 years. 63% were female, and the average BMI was 38.
Sounds great. So what were the results of this study?
Okay, so overall, they found weight loss ranging from 12% to 16% with Maridebart, compared with 2.5% weight loss with placebo. So that's impressive, right? On average, we could say that patients lost almost 15% of their body weight. In the diabetes cohort, the mean change in A1C was a fall of approximately 1.5%. It varied a little bit by the dose, but I don't want to go into those weeds. And there was no change in A1C for patients who received placebo. The side effects of this drug were unsurprising. It's the typical side effects that you see with a GLP-1 type medication. These included, GI side effects, nausea, vomiting, constipation, and importantly, side effects were less frequent with the lower doses of the medication.
Wow, that sounds like a pretty incredible weight loss outcome for the intervention group.
Absolutely. The idea that you can take a medication once a month and it leads to that kind of weight loss, very impressive.
Definitely.
So limitations, this was a phase 2 trial. It was industry funded. On the rounds table, it's much more often that we are discussing phase 3 trials, but this really caught my eye, again, because it's once a month. It also makes me think a little bit on side effects. You know, let's say a patient is on this once a month medication and they need to have an urgent surgery like today. Well, the half-life of this drug is 21 days. So that means it's circulating in their system for a long time, which means even if they fasted before midnight for the surgery, odds are their stomach will be full of gastric contents.
Oh, wow. That's definitely something to think about. And Mike, as a practicing physician, would you say this is practice changing?
It feels like a future game changer. Right now, this medication is still in the phase 2 development, so not widely available. But I can see this as being a really useful tool for patients who I care for with obesity, but they don't want a once weekly medication, but they'd like a once monthly medication. So stay tuned for when it one day, I'm sure, is approved by FDA and Health Canada. All right, that's one down, two to go. Danielle, what article do you have up next?
All right. So I have an article called Orforglipron, an oral small molecule GLP-1 receptor agonist in early type 2 diabetes for the Achieve-1 trial investigators.
Wicked. And this was another, late breaking time publication in the New England. What was the research question for this study?
The research question was, for patients with type 2 diabetes, by how much did orforglipron change glycated hemoglobin level?
Yeah, this makes sense to me as somebody who's a big fan of GLP-1 analogs. There are certain patients that are just like, Doc, I'm not going to take an injection. I don't care how good this medication is. And we do have an oral version of semaglutide available, but it's really nice to see other drugs in the pipeline. So what was the study design here?
So this was a phase 3 double-blind placebo-controlled trial taking place in 5 countries, which were the US, Mexico, Japan, India, and China. The population included individuals with type 2 diabetes inadequately controlled with diet and exercise alone. The inclusion criteria were you had to be over 18, you weren't receiving any other oral or injectable glucose lowering medication within 3 months before enrollment in the trial, never having received insulin therapy, an HbA1c of less than 7%, but no more than 9.5, and a BMI of at least 23 and stable weight. The exclusion criteria were a history of pancreatitis, any liver disease, AST and ALT no more than 5 times the upper limit of normal, and an estimated GFR of less than 15. The intervention, as we mentioned, is an oral agent. It is oral orforglipron, another mouthful to pronounce, daily at a dose of either 3 milligrams, 12 milligrams, or 36 milligrams. The comparator was placebo, and the outcome was a change in HbA1c. There was a secondary outcome as well of percent change in body weight, non-HDL cholesterol, and triglycerides, and this occurred over 40 weeks.
Wicked. So, Danielle, if I have this right. I've been known to make mistakes, so listen closely and correct me where I'm wrong. This study included patients with type 2 diabetes. They had inadequately controlled diabetes despite diet and exercise. These individuals had an A1C between 7% and up to 9.5%. They weren't on any medications for their diabetes. They hadn't received insulin previously, and they excluded patients who had pancreatitis. They had liver disease, a GFR of less than 15, and they were randomized to this mouthful, which I'm just going to call Orfor. So they got randomized to Orfor or placebo, and the primary outcome was change in A1C.
You got it.
All right, wicked. And what did the included patients look like?
So the included patients, there were 559 of them in total. 143 got Orfo at 3 milligrams, 137 at 12 milligrams, and 141 people got it at 36 milligrams. 138 were randomized to the placebo group. At baseline, participants had a mean duration of type 2 diabetes of 4.4 years, a mean HbA1c of 8%, a mean BMI of 33, 48.1% were women, 38.3% previously received a glucose lowering agent. Additionally, demographic and clinical characteristics of the participants at baseline were similar among the trial groups.
Gotcha. Okay. So, relatively small trial, average A1C of 8%. Most had diabetes for 4 years, and average BMI of 33. So, what did they find? Was Orfo superior to placebo to reduce A1C?
Orfo was superior to placebo to reduce A1C. So they saw with the 3 milligram Orfo group, there was a negative 1.2% point reduction in A1C. With the 12 milligram group, there was a negative 1.5% point reduction. And with the 36 milligram group, there was a negative 1.5% point reduction. So yes, this was statistically superior to placebo with respect to the primary endpoint.
Awesome. And other key results to summarize?
Yeah, so the mean HbA1c at 40 weeks was about 6.5 to 6.7% with Orfo. There was also a pretty significant body weight reduction. So we saw with the 3 milligram group, there was a negative 4.5% body weight reduction. The 12 milligram group had a negative 5.8% reduction, and the 36 milligram group had a negative 7.6% reduction in comparison to the placebo, which was a negative 1.7% reduction. There were some adverse effects. Most frequently were GI, but like you mentioned, this is quite common with the GLP-1. And these GI effects occurred during the dose escalation period mostly. There were no events of severe hypoglycemia. Rescue therapy was needed for persistent hyperglycemia in 4.4 to 6.3% of participants in the intervention group and 23.2% of participants in the placebo group. Orfo was stopped due to GI side effects in 5% of the intervention group, and antidiarrheal meds were needed in 8% of participants in the intervention group and 4% in the placebo group.
Yeah, I mean, these are pretty impressive results. When I sort of reflect on how large of a reduction in A1C do we see with some other diabetes drugs, SGLT2s, my precious SGLT2s, they will never give this large a reduction in hemoglobin A1C. DPP-4 inhibitors, similarly, you won't see this impressive a reduction in A1C. So, a definite gold star for that one. And these results are in line with what we've seen with other GLP-1s, but seemingly a lower risk of GI side effects compared to injectables. So this really feels exciting. But what are some important limitations of this study?
Yeah, so a limitation of the study was that the people included in this trial were people that were only treated with diet and exercise. So this trial wasn't really generalizable to the entire type 2 diabetes population who may be on multiple medications at once.
Like some people will always criticize these trials saying, why was it compared to placebo? You have somebody with an elevated A1C. Why didn't you compare it to an SGLT2? Why didn't you compare it to metformin? Well, my friends complained to the FDA because they're just following the rules that the FDA has set out. The first step is to show, does your molecule, does it beat placebo? But all of us as practicing clinicians, we'd much rather know, how does it compare to another diabetes drug? Anyway, Danielle, did this trial feel practice changing for you?
Well, I'm only a med student, so I will keep you posted when I mention this on rounds.
There you go. That's the correct answer. If you said, "Oh yeah, I've actually already started prescribing it," that would feel like a red flag. So
definitely not. No.
So 2 trials down. Last one up. This one actually isn't even a randomized trial, but my brother's not here. Otherwise, he might say, "Mike, we only do trials." But I'll just keep going. So this is stem cell derived, fully differentiated islets for type 1 diabetes, again, published in the New England Journal of Medicine in June 2025. Continuing on with the theme of today's episode, which is hard to pronounce medications, the research question here was, is zimilecl, I'm just going to call it Zimi, which is an allogenic stem cell derived islet cell therapy, is it safe for adults with type 1 diabetes?
Wow, this is really cool stuff. I'm excited to hear about the study design.
Yeah, it really is cool. I mean, so often we talk about personalized medicine, and I'm sort of looking around wondering, when is it going to come? Maybe it is coming. So this was a phase 1/2 study of Zimi in persons with type 1 diabetes. They had different sort of parts to this study. So part A, they got a half dose of the stem cells as a single infusion into the portal vein. So a reminder for our listeners, this wasn't just like a IV or intra-arterial infusion. This was intraportal, and I'd have to imagine it was done by an interventional radiologist. And there was an option for a second half dose within 2 years. Parts B and C received the full dose of the single infusion of stem cells, again via the portal vein. And the hope is that the stem cells, after injected into the portal circulation, would then latch is the non-medical word I'll use, latch onto hepatocytes, and you would hope that those cells are now able to, take on the role of the beta cell in the pancreas to produce insulin. All patients did receive immunosuppressive therapy because, it makes sense. They're receiving these allogeneic stem cells. You don't want your body to reject them. The primary endpoint in Part A was just the safety. For the other part of the study, it was freedom from severe hypoglycemia, as well as achieving an A1C of less than 7%. Who did they include? Average age of 18 to 65, all had type 1 diabetes. All of them had at least 2 severe hypoglycemic events in the past year. All of them were dependent on insulin for at least the past 5 years. As mentioned, the intervention here was infusion of Zimi through a catheter in the portal vein. There wasn't a comparator. It was just a single-arm study. And, the interest was safety and maybe some hints at potential glycemic control.
Awesome. So what did the patients look like?
So this was a very small study. 14 patients were included. Average age was 43. 33% were female. All were white. Average BMI of 25. Average A1C of 7.8%. The mean insulin dose on average for these patients was 40 units per day. It is important to maybe note that this is part of a larger study of 28 some odd patients, and they just focused on 14 patients who had at least 1 year of follow-up. I wish they just included all 28, but they did what they did.
Gotcha. Okay, so what were the main results?
So again, in the study of 14 patients who completed at least 1 year of follow-up, at baseline, C-peptide was undetectable in all 14 participants. So, a quick reminder, when somebody has undetectable C-peptide, that is showing you that their body is not making any insulin whatsoever, right? So it really confirms, okay, these people probably truly had type 1 diabetes. So what did they find? So after this infusion, all of them had engraftment of the islet cell function as evidenced by detection of C-peptide afterwards. So I use the non-medical word of like latching onto the hepatocytes, but really the medical word is engraftment. So all of them had engraftment. The most common adverse event associated with the infusion was neutropenia. Other adverse events included some GI side effects, as well as some headaches, mouth ulcers. I'll note up front that 2 patients did die, but I think it was unrelated to the stem cells. One had severe dementia, and the other had cryptococcal meningitis, which was a post-op complication from a sinus surgery. So for all 12 of the remaining patients, all of them were free from severe hypoglycemia, and they all achieved an A1C less than 7% and spent more than 70% of time in target or in range, which is just like really incredible. 10 of the 12 patients were completely independent of insulin at year 1. How amazing, right? Since the time these individuals were diagnosed with type 1 diabetes, they have been dependent on insulin. And now with a single infusion of the stem cell, 10 of them don't need to be on insulin and have had the best glycemic control they've ever had.
Wow, I can't even imagine how life-changing this is. So were there any limitations to this small study?
Yeah, absolutely. Small study, as you alluded to. You hit the nail on the head. Really small study and a short follow-up period. For these individuals with type 1 diabetes, we want to know 5-year outcomes, 10-year outcomes, not just 1-year outcomes, but I totally get it. You got to start somewhere. This study, I think similar to all the studies today, they were sponsored by pharma, and I'll just read one of the lines from the methods section, and it says, 3 of the authors, in brackets, all employed by the sponsor, wrote the first draft of the manuscript with assistance from medical writers employed by the sponsor. I gotta be honest, I don't know why we need to be having medical writers write up the manuscript. I think as a researcher, this is your job to write up the manuscript, but those are my editorializing comments for this.
I mean, yeah, that definitely does sound like a limitation to me.
Yeah, totally. And I know what you're going to ask. And, is this practice changing? Not yet. This is just in a phase 2. So I guess similar to that once monthly Maridebart we talked about, not available to be prescribed even if you wanted to. There is an ongoing phase 3 trial that is actively recruiting, but this feels really special, and I hope that listeners can't see, but my fingers are crossed. I hope that these results are borne out in the phase 3 data, because this would absolutely be a game changer for people living with type 1 diabetes.
Awesome. I can't wait for that to come out, and I can't wait to see where this goes.
Yeah, me too. Okay, Danielle. Well, that's it. Your first ever podcast done. Danielle, was it harder than you thought it was going to be? Easier than you thought it was going to be? What did you learn?
I guess I would say it was kind of hard to multitask and read and think out loud at the same time, but I loved it. It was super fun. I learned a lot, and I just can't wait to see what happens next.
Awesome. Well, thanks, Danielle. We'll definitely have you back on the show. We always end with, good stuff, some sort of a good news story that has caught our eye, or just something we want to share. For me, you've been a part of building trial files, and we now also have a diabetes trial files. So we will share that in the show notes, and listeners can sign up to receive bite-sized summaries of randomized trials, both recent and from years gone by. And what's on your plate, Danielle?
I guess the one good thing is I just finished Med 2, so that's a big step for me. And
Congrats.
thank you.
Yeah, congrats, Danielle. Clerkship, I get it. It's stressful and the days are long. Residency, also kind of stressful and the days are long. But, you'll blink, and before you know it, you'll be a staff physician and you'll be having a podcast with a Med 2 at McGill. So anyway, Danielle, thanks for your time and best of luck on the wards.
Thanks so much. Thanks for having me.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.